This week we have an important topic on cardiovascular emergencies. So we'll be talking about any and all emergencies that involve the heart as well as the vascular system. If you take a look at the back side of the medical history form, there are a lot of conditions that involve the cardiovascular system. First, in the top left-hand side, there are the conditions that would require antibiotic prophylaxis to prevent against infective endocarditis. So we've already talked about those a few weeks ago, and that's the artificial heart valves, someone who's had previous infective endocarditis, if there's damaged heart valves when in a transplant, or someone that has congenital heart disease and the different variations of congenital heart disease, whether it's unrepaired or repaired and how long it's been since it's been repaired. So we're not going to go into that today because basically those items are more, we need to know them because of antibiotic prophylaxis and if the individual needs to take antibiotics prior to their dental appointments. For this lecture, we're going to focus on further down on the left-hand side, cardiovascular disease. We're going to talk about what falls into this category of cardiovascular disease as an umbrella term. And then we're going to go into talking about angina, myocardial infarction, heart failure, high and low blood pressure, pacemakers, and cerebrovascular accident or a stroke. There are other heart conditions listed, but we're not going to go into them in great detail because they aren't something that is going to potentially cause a medical emergency. Before we talk about actual medical emergencies involving the heart, I think it's important to do a quick anatomy review so that when we talk about the issues or the conditions of the heart, we're familiar with what they are. So first, there are 4 chambers of the heart. We have 2 atrias and 2 ventricles. And we have 1 atria and 1 ventricle on the right side and 1 atrium and 1 ventricle on the left side. So you can look to the right to that picture there. They like to color code things in blue and red. So in the blue there, we have the right atrium that is superior to the right ventricle, or it's over or on top of the right ventricle. Same thing with the left side. The atrium is over or superior to the left ventricle. So atria is on top and ventricles on the bottom. Next, the heart wall or the sac that encloses the heart is called the pericardium. This is what is covering those ventricles and atriums. So there's 3 layers to the pericardium. There's the most external layer or the epicardium. The myocardium is the muscle layer. Myo, the prefix myo stands for muscle. And then endocardium, the internal layer, and that's what's lining those chambers of the heart. So from the most superficial to least superficial, it goes the epicardium, then the myocardium, and then the endocardium on the inside. And you can see that on the right-hand side, that picture, the cutout of those different layers of the pericardium. Next, we have some valves that separate those atria and ventricles. So they're called the atrioventricular valves. The mitral valve is located on the left-hand side. That's why that's color-coded in red to go with the left-hand side. It's also known as the bicuspid valve. And then there's the tricuspid valve on the right-hand side. As a side note here, there is a condition called mitral valve prolapse, and that's a condition that's also on the medical history form. And in this condition, the mitral valve on the left-hand side is damaged. So because it's damaged, it allows blood to pool. The blood can backflow instead of going from the atria to the ventricle. It can kind of backflow from the ventricle back to the atria. So it used to be a condition that required antibiotic prophylaxis. It is no longer one of those conditions and recommended unless it's specifically recommended by a cardiologist. Here's a diagram and description of how the blood flows through the heart. So I'm going to go through the diagram, and if we look at the top left-hand side, we come down past where it says pulmonary veins from lungs. We're looking at that big blue area, and that has an RA in it, which stands for right atrium. So it's blue because this blood is oxygen poor. It needs to be oxygenated. So the blue oxygen poor blood enters the right atria. Then it moves from the right atria through that tricuspid valve into the right ventricle. And now we're on the bottom of the diagram looking at the right ventricle. We're still oxygen poor blood. That oxygen poor blood is pumped through the pulmonary artery. That's what that PA stands for. Now we're going up to the pulmonary artery that goes to our lungs. The lungs oxygenates the blood. And now we're going to the pulmonary veins. And now we're red because we have oxygen-rich blood. The blood was oxygenated in the lungs, and now it's coming back to the heart. So we're now in the left atria. That pumps through the mitral valve to the left ventricle. And then finally, the left ventricle pumps the oxygen-rich blood out through the aorta to the rest of the body. So it's good to know the flow of the heart. We know that it enters the body on the right side, the right atria, and exits the body from the left ventricle. Cardiovascular disease is an umbrella term for a lot of different abnormal functions of the cardiovascular system. So we can have abnormal functions of the blood vessels themselves, abnormal function of the heart muscle, or both of those blood vessels and the heart have an issue together. And this can be congenital or acquired. And if it's acquired, there are a lot of predisposing factors that one can have that can increase their risk for cardiovascular disease and cardiovascular related emergencies. A lot of times if the patient isn't going to a general physician and getting checkups, they don't get their blood pressure monitored, they don't get their blood work done regularly, they might be unaware that they even have a cardiovascular issue. Hypertension is also sometimes referred to as the silent killer. So patients don't really feel sick until their blood pressure is high and high for an extended period of time. And this is one way that we as dental professionals can bridge the gap between someone who's not getting their general physician's checkups, but they are coming to the dentist. And that's another reason why we take blood pressure at their initial appointments and at their recare appointments. And this is something that's actually recommended by the American Dental Association. And remember, vital signs are going to be crucial to being able to know how to respond in a medical emergency, and they're also a great way to identify someone that has undiagnosed cardiovascular issues. And cardiovascular disease is characterized by the inability for that person to respond to stress. So their body does not respond well in a stressful situation, either if that stress is induced by emotional or physical. And a lot of times in the dental office, we're causing that emotional stress. And stress and the inability to respond to that is going to be a main factor in having a cardiovascular medical emergency. So if we see someone that has cardiovascular disease marked yes on their medical history form, we're going to immediately think stress reduction protocols. We want to try to make sure we're not putting this individual in any extra stress that they don't need. And unfortunately, if they don't know that they have cardiovascular disease, there's not much we can do other than monitor their vital signs and make necessary referrals. I talked about predisposing factors or factors that will increase the risk of someone developing cardiovascular disease or having a cardiovascular emergency. So we talk about them as being non-modifiable or modifiable to some degree. Non-modifiable factors a person can't get away from. There's nothing that they can do to change these factors. And this is something like heredity. So you can't change if your mother had a history of cardiovascular disease or if your father had a heart attack. You can't change your age, your gender, your race. This is something that's all within you as a person, and there's nothing you can do to change it. And then atherosclerosis. If you have more hard, narrow arteries, which is what atherosclerosis is, there's not much that you can do to change that. Then we have modifiable factors, something like smoking, obesity, and going hand in hand, lack of exercise and eating a high-fat diet. So this is something we can change. A person can change the amount of exercise that they do. They can change their diet, the amount of fat that they're eating in the diet, or just their diet in general. They can stop smoking or reduce smoking. So there's certain things that a person can do to reduce their risk of getting cardiovascular disease. And then there's a category of this is potentially modifiable. It depends on the person and the situation. So something like stress, that can really pose a risk factor for cardiovascular disease. And sometimes we can get around stress, but sometimes you can't, depending on your work life, if it's work that's stressing you out, or if you have family issues at home that are causing a lot of stress. Maybe you're in dental hygiene school and you're stressed out constantly. So there may be a way to modify that, but maybe not completely. High blood pressure, high cholesterol, and diabetes. So these are all potentially modifiable, usually by diet and exercise and medication. But it depends on, there's only so much diet and exercise you can do that'll help cholesterol at times. So there may be a way to modify it by changing your lifestyle, but it might be to not the complete degree that your cardiologist would like. Here are our list of conditions that fall under cardiovascular disease. So again, we have blood vessel conditions, heart muscle conditions, or both heart vessel and heart muscle conditions. So for blood vessels, we have atherosclerosis, coronary artery disease, and aneurysms. For heart muscle conditions, we have myocardial infarction or a heart attack, heart failure, and heart arrhythmias. And finally, we have a condition that relates to both the blood vessels and the heart, which is called angina pectoris. First, we're going to talk about blood vessel conditions. So we have atherosclerosis and aneurysms. Atherosclerosis is a buildup of cholesterol and plaques, and what that does is cause the artery to harden, and it's not as elastic, and it also narrows the diameter of the artery. And when the artery is hardened and more narrow, it reduces and obstructs the ability for blood to flow through it. And a lot of the times it's going to result in high blood pressure because the arteries aren't able to give way or stretch because they're too hard, they're not as elastic. And also they have a narrow diameter, so we have the same volume of blood in a smaller area because of that plaque and cholesterol buildup. And we'll talk about this more in your later classes, but that plaque buildup has been shown that there's a link to the plaque buildup in the arteries that is the plaque buildup in our mouths. So there is a systemic link between what's going on in our mouth and what can happen in our heart. And that's going to be probably farther down the road. You'll learn more about that. And then our next blood vessel condition is an aneurysm. And this is where the blood vessel has a abnormal widening or a ballooning effect. And you can see in that picture there, you have the normal artery and then that ballooned out artery or vessel there. And because it balloons out, it is weaker, and there is a chance for it to rupture. And if it ruptures, then we have a hemorrhage or excess blood. So we'll talk about that here when we talk about cerebrovascular accidents. A condition that involves both the blood vessels and the heart muscle is called angina pectoris. And this is where a person experiences chest pain or discomfort from myocardial ischemia. And this is the heart muscle not getting enough blood and oxygen. So Ischemia means lack of oxygen, and myocardial means to the heart muscle. So it can be caused there's a bunch of different causes for angina. It can be due to insufficient blood supply. There could be a decrease in the oxygen in the blood that's going to the heart muscle. There could be a narrowing or constriction of an artery, so atherosclerosis, and because of that, the heart's not getting enough blood supply. Or the patient could be experiencing more cardiac demand. Either they're doing some kind of exercise, or they're having stress placed on them that is increasing the heart's demand, and the heart has to work harder, and it's not able to respond well. We talked about not being able to respond to that stress or that demand. So the patient with angina is going to experience chest pain, but it's from a temporary lack of oxygen or blood to the heart muscle. There are 3 types of angina, and based on some follow-up questions, you can usually figure out what type of angina your patient has. And it helps to know this because it's going to help us know who's more at risk. So someone with stable angina is someone who has coronary artery disease and gets the angina discomfort or pain as a result of physical or emotional stress. So this is someone who has the discomfort when they're moving, when they're either exercising or stressed. Typically, their pain lasts from 1 to 15 minutes, and it will be relieved with medication. So this is someone who has stress or has excess cardiac demand. It's only lasting less than 15 minutes, and medication that they take for it will relieve their discomfort. Then there's variant angina. And this is someone who has a spasm of the coronary artery that is going to narrow the artery, constrict the artery, and it's going to temporarily stop the blood flow to the heart muscle. This is not associated with those cholesterol plaques that we talked about earlier. That's not what's narrowing it. It's the spasm that's narrowing it. And this can occur at rest, exposure to cold or hyperventilation, but it's also relieved with medication. And finally, our most risky case of angina is called unstable angina. And this can occur at rest. The patient's not doing anything. They could be laying down, and it happens very quickly, and it can last up to 30 minutes. Unstable angina can increase in duration, so how long it lasts. It can increase in frequency as far as how often they're experiencing it, or intensity. Sometimes it can be more mild to sometimes be more severe, or the pain can gradually wave to more intense pain and then come down from that. So these people have a harder time identifying normal angina pain because it changes for them. And they can take medication, but they might require an increased dose of medication, or it might not even work for them. So unstable angina is definitely your more risky angina patient versus someone with stable angina.
Nitroglycerin is the drug that's going to treat angina. So nitroglycerin is a vasodilator, which means it's going to dilate those coronary arteries so that the heart muscle receives more blood and therefore receives more oxygen. It's a core drug in the medical emergency kit, so we have to have this drug in our medical emergency kits. There's a couple different ways it comes, and if you look at those pictures on the right-hand side of the screen, the first one is the sublingual tablet, and then there's the sublingual spray. So it is best administered sublingual, which means underneath the tongue, and that's where it's going to be most readily absorbed. It's going to get to the bloodstream the fastest in that manner. So we try to have our patients take it if they're carrying it with them. If a patient has history of angina, they should be carrying their own nitroglycerin, and we should allow them to administer it themselves. They should be able to do that, so it's their prescription and they should be taking it. If they don't have it, that's why we have it in our emergency kit so we can use it as backup. It also has a very short shelf life, so this is one of the drugs that's going to be replaced more frequently as we periodically check the medical emergency kit. Signs and symptoms of angina. So again, we have that chest pain. It's usually in the substernal region, so if you feel your sternum in the middle of your chest, that's where the chest pain is usually. It can be described as a heaviness or a squeezing sensation, and there also can be a crescendo decrescendo pattern, so it can come in kind of waves of pain. So it can be more painful and then subside and then come back. Sometimes it's hard to localize to one certain area. And then this patient can also experience numbness or tingling that radiates to the shoulders, arms, jaw, or throat. Usually, pain is going to last 3 to 5 minutes, but the longer it lasts, the more likely it's going to turn into a myocardial infarction or a heart attack. So we need to make sure that we're identifying quickly the signs and symptoms and seeing if the patient can determine between having their normal angina pain or if it's something different, if it's more severe, and that's when we're talking about myocardial infarction. Our first line of defense is to try to prevent angina. So the best way to do that, like I talked about earlier, is employing our stress reduction protocols. We're going to try to keep our appointments short. That's going to overly place stress on them if they're a long appointment. If we want to try to keep our appointments on time and reduce the anxiety of someone sitting out in the waiting room. Make sure we're using appropriate pain control. Pain equals stress, and we don't want to put unnecessary stress on our patients. As another side note here, and you're going to learn more about this in your pharmacology class, but for someone with angina or cardiovascular disease, we're going to use a cardiac dose of vasoconstrictors. We don't want to constrict their blood vessels more than we need to. So if we're talking about carpules of anesthetic, the cardiac dose is no more than 2 carpules of 1 to 100,000 epinephrine. So that's a side note, and you're going to learn much more about this when you have your local anesthesia course. And you're going to want to consider using anti-anxiety medication if the patient is very stressed in the dental chair. So something like nitrous oxide, a sedative, or an anti-anxiety medication such as Valium. If someone does experience angina in your chair, the first management is going to be to stop treatment and position the patient to the upright position. If they've never had a history of angina before and they're experiencing chest pain for the first time, immediately we're going to call and activate emergency medical services and call 911. If they've had angina pain before, we're going to go ahead and monitor their vital signs, and we're going to administer, either they're going to administer their own. If they don't have it, we'll administer nitroglycerin sublingual, either a tablet or 1 to 2 sprays. We're going to give them 100% oxygen as we wait for them to recover from the chest pain. If we need to, we can re-administer the nitroglycerin as needed, so they can get up to 3 doses in a 10-minute period. If after 10 minutes and 3 doses the pain's not relieved, then we're going to call emergency medical services because the pain has gone on too long at this point and it's potential that they are having a heart attack, so we need to call 911. Our follow-up questions if someone marks yes for angina on their medical history form. First, we're going to ask them what triggers their angina. This is going to help us determine what type of angina they have and the risk of them having a angina issue in your chair. So we want to know, is it caused out of the blue, where they could just be sitting down, or is it more when they're moving and they're pushing furniture or going up a flight of stairs? How long and how frequent does it happen? How long does it typically last? Does it typically last 3 minutes, or does it typically last 15? That's always good to know. Do they use nitroglycerin? They probably do, but some people don't need to if it's very short in duration. And then when was your last episode? And have you ever had a heart attack? So hopefully if they have had a heart attack, they've already marked that on their health history form separately. But you never know. Sometimes people can have different interpretations of what is considered a heart attack. So this question may open up the door to talk about some other things. It's going to open up that dialogue for the patient to get talking. And remember, we're investigators going through the medical history. We're detectives and trying to find out the missing pieces to make sure that we're knowing the risk for our patients. And sometimes that means we have to dig a little deeper. All right, we're going to move on to talking about myocardial infarction, commonly referred to as an MI or heart attack. And this is a condition that's similar to angina, except for a portion of the myocardium, the muscle layer of the heart, dies as a result of oxygen deprivation or ischemia. So whereas angina is a temporary loss of oxygen in the area, this is it's a longer loss of oxygen, and it's going to result in the death of tissue or the muscle there. It can be caused by atherosclerosis, vasospasm, or a thrombotic blockage. Signs and symptoms of a myocardial infarction are similar to angina, but a little bit more severe. So again, chest pain, and usually that substernal area, but it's usually occurring at rest, or as the person rests, it continues with rest. It doesn't go away. It can be described as the compressing or that squeezing pain, and it can also radiate to the arm, neck, and mandible. The important thing to know to differentiate between angina and an MI is the severity of the pain is not going to be relieved by nitroglycerin. This person can also experience vomiting or nausea. They can be sweating, but they have cold to the touch, clammy skin. They're going to have labored breathing, feel weak or fatigued, and then they can start to have signs that we can see. So like an ashen gray skin color, a cyanotic or purplish color to their mucous membranes, their gingiva. And then these people are going to have a sense of impending doom. So when we talk about having someone differentiate between angina and a heart attack, if they've ever had angina before, if they're having a heart attack, most likely they're going to know something is different, something's really wrong, more than just their typical angina pain. If we think that someone might be experiencing a heart attack in our chair, the treatment is very similar to angina. So first of all, we're going to try to distinguish between, can we tell if it is a heart attack or angina? So first things are the same. So we're going to stop dental treatment, and we're going to be positioning the patient to the upright position. If the patient has a history of having angina, we're going to be asking them, does this feel like your typical angina pain? And if it does, we're going to be giving them, or they're going to be taking their own nitroglycerin. Same thing, we're going to be providing 100% oxygen, so putting that oxygen mask on them and allowing them to breathe deeply, keeping them as calm as we can. If the nitroglycerin, if we give it to them and it does not relieve the pain, we're going to be calling 911, activating the emergency medical services, and try to keep the patient calm. A lot of times when the patient is having a heart attack, they can be stressed out and trying to move around and, shake it off. Well, we need these people to be at rest as possible. So keeping them calm, don't let them move around, just have them sit there. And then we're going to be getting the emergency medical kit, and we're going to be getting that aspirin out of there. So we're going to administer 325 milligrams of aspirin, and this is going to be either crushed and they can swallow it, or they're going to chew it and swallow it. And what aspirin's going to do is thin the blood and potentially clear any blockages that they might be having to their heart. A couple weeks ago, I was at a medical emergencies continuing education course, and the gentleman there, he spoke about medical emergencies, and it was kind of interesting to see how he condensed our 16-week course into a course of about 2 hours. But it was more of a refresher than anything. But he added a slide into his course that I decided to add into ours as well, and it was about a mnemonic device called Mona. And basically, he told a story about how he dated a girl named Mona, and she was a heartbreaker, and she dumped him outside of an Applebee's. So, Mona stands for morphine, oxygen, nitroglycerin, and aspirin. And this is what we're going to be doing in the case of someone having a either angina that turns into a heart attack or a heart attack. Obviously, in the dental office, we are not administering morphine. That is in a medical office, or he was an oral surgeon, so he has a little bit more access to those kind of medications. But for our offices, and for you guys to know, we're going to be knowing the last three. So oxygen, nitroglycerin, and aspirin, especially aspirin if it is suspected that it's a heart attack. If someone's had a heart attack in the past, we need to know how soon it's been since their heart attack. So elective dental treatment, which is what we provide as far as dental hygiene care, it's usually not emergency care, but it should be postponed 6 months after a heart attack, and we want to get consultation from the cardiologist. So we're going to have that cardiologist let us know how at risk our patient is for having another cardiovascular emergency in our chair. Typically, we take the postponement of 6 months, and if we're not certain about the patient's ability to meet those 4 METs of functional capacity, we may need to get medical clearance before we can do elective treatment. Another way to handle these patients is to follow stress reduction protocols. If a patient has had a previous heart attack or has cardiovascular disease, we want to make sure we're not causing any additional stress for their body or heart to take. The patient should have no cardiac symptoms for at least 1 month prior to treatment. So they shouldn't have any kind of residual effects in the last month prior to your treatment. So just because it's been 6 months doesn't mean that they haven't had any symptoms. So we do want to be asking those kind of questions as far as how long has it been since you had any cardiac symptoms. And just like the typical normal, the blood pressure needs to be less than 180 over 110 with a normal pulse and a normal rhythm. There is some new guidelines regarding how soon we can provide elective dental care to a patient. So a lot of the new guidelines want to focus on the patient's functional capacity, because we have to remember that patients heal differently. Just when patients heal differently from dental work, patients heal differently after a heart attack. So there are some patients that bounce back really quickly after a heart attack and have no symptoms and have no residual effects, even a month after having a heart attack. So the new guidelines are saying let's focus on the patient's functional capacity rather than relying on the time passed. So we need to determine, is the patient being compliant with their medications? If they've suggested that the patient changes their lifestyle as far as smoking, exercise, and their diet, are they being compliant with that? And are they meeting that 4 MET functional capacity? So this is something like, can they do light housework as far as washing the dishes? Can they climb a flight of stairs carrying some groceries? Walk at 4 miles per hour? I don't know why it says MPG. Or run a short distance. So if you've ever been on a treadmill at the gym, walking at 4 miles per hour is a brisk walk. It's not a slow walk by any means. So this might be something that you might run into when you're out in private practice as far as not following that 6 month time period. There might be dentists that want you to see a patient sooner, and as long as they have cardiologist approval, it's going to be okay. But as far as RCBC and the guidelines that we're going to enforce and follow, we're a little bit more strict and a little bit more cautious because we have a lot of risk being at a school. So we're going to remain with the standard 6-month guideline for the amount of time passed to treat a patient after a heart attack. Okay, so here is a review slide of when to activate the emergency medical services, when to call 911. So if someone has chest pain that is not relieved with nitroglycerin, so if it's not relieved in 10 minutes, we're going to be calling the emergency medical services. If someone has a new onset of chest pain, so someone who's never had any kind of history with angina, never had any previous history of chest pain, never had previous heart attack, nothing, we're going to be calling emergency medical services from the beginning. Even though it might just be angina, we want to be safe than sorry. This patient doesn't have any history of it, so it could not be angina and it could be a heart attack. And finally, if the patient has a previous history of angina, but the pain is not typical of their angina pain, so if they're saying this is different, I feel it's not the same pain as I usually have, then we're going to be calling the emergency medical services right away. The next cardiovascular disease we'll talk about is heart failure. So we usually talk about heart failure as right and left side heart failure because there's different symptoms between the two of them. So what I want you to know in general terms is that when the right side of the heart fails, pressure is going to be built up in the tissues that supply the right side of the heart, and that's going to be our lower extremities. So this is going to be like our feet and our ankles and our lower legs. And because of that pressure buildup, we're going to get swelling or edema in the areas. This can lead to fatigue or cyanosis in the mucous membrane. So cyanosis, that purplish bluish color, and it can be found in the lips and nail beds. And if we do a thorough extraoral exam, we can sometimes notice this on a person. When the left side of the heart fails, edema or swelling is going to collect in the lungs, and this is going to cause dyspnea, which is labored breathing, especially when the patient is reclined. So if patient has heart failure, they should not be receiving elective dental hygiene care or elective oral care unless their heart failure is well controlled. So most of the times we're going to be wanting to get medical clearance for these patients to make sure that it's safe for us to treat them. Here's a quick slide on pacemakers. So pacemakers are placed subcutaneously, so underneath the skin, and they have a bunch of wires that provide electrical stimulation to the heart. So it is artificial stimulation to the heart, and it helps to regulate the rhythm of the heart. And these are for people, they're placed for people who have cardiac arrhythmias or their heart rhythm is off. In the past, we used to be more worried about pacemakers and what we can or cannot do to patients with pacemakers, but they've changed the way that they make them now so that we don't really have too many concerns with pacemakers. We used to have patients take antibiotics prior to their appointments, but very few patients will even tell you that they need to. It's not something that's been recommended for quite some time now. Our final medical emergency that we'll talk about this week is a cerebrovascular attack, also abbreviated as CVA, and most commonly referred to as a stroke, and what we probably know it as. A cerebrovascular attack is defined as a loss of brain function resulting from interference of the blood supply to a part of the brain. So it's similar to a heart attack because there is a loss of blood, but instead of to the heart, it's to the brain. And it can result in a lot of permanent damage to a person. It can result in death, but if it doesn't result in death, the permanent damage could be disability in motor skills and motor function, disability with communication and perception. And these patients also can become hemiplegic, so they can be paralyzed on one side of the body, or hemiparesis, meaning they can have a weakness on half the body. And it can be caused, a stroke can be caused by 3 different kind of issues. We're going to go through all of them, but they can be a thrombosis, an embolism, or a hemorrhage, and they're all to do with the brain. So cerebral means brain, and it would either be a thrombosis, embolism, or hemorrhage. A stroke, if it's very severe, can be followed by death in minutes, so time is definitely of the essence as far as recognizing a stroke and being able to get them the care that they need. But if they don't have as severe of an attack, they can have those residual signs that can be, not too noticeable to really debilitating for them. There also are some predisposing factors that can increase the risk for a patient to have a stroke. And some of them are similar to a heart attack, or cardiovascular disease. So atherosclerosis, hypertension, hypocholesteremia, high triglycerides, some modifiable factors like smoking, and then just having cardiovascular disease can also put them at a risk for a stroke. A patient with diabetes, and also someone taking long-term oral contraceptives have shown to have a link between that and a stroke. One of the causes of a stroke is a cerebral thrombosis. And the risk factors for having a cerebral thrombosis are mainly due to atherosclerosis, that hardening and narrowing of the arteries, or hypertension. So cerebrothrombosis, a thrombus, is a clot that forms in place. So it's a clot that forms within an artery. In this case, it would be a cerebral artery because it's in the brain. And that clot is going to completely block the blood flow in that artery. So a thrombus is a clot that forms in the artery itself, and it stays there. It's in the artery that it forms in, and it stays there, and then finally ends up blocking that artery. A lot of times, a cerebral thrombosis is going to occur during sleep, and this patient is going to awake with the signs of a stroke. So something like stuttering, weakness, paralysis, maybe on half of the body, and then they can have more gradual deficits going on further after that. So about 1 to 3 days after, there can still be some symptoms or signs of the stroke. The next cause is a cerebral embolism. So an embolism forms somewhere else in the body. It's a clot that forms somewhere else in the body and travels to the brain. So it can be referred to as a wandering clot. So it forms in some other artery. That clot breaks off and becomes lodged in a cerebral artery. So where a thrombus forms in that cerebral artery, an embolism forms somewhere else and chunks off and goes to that cerebral artery and blocks it off. And again, you're reducing the blood flow or eliminating the blood flow to the brain beyond that clot. So in this case, it usually occurs very rapidly, and the damage is worse at the beginning. And usually these patients don't notice an increase in severity afterwards, and they could experience a quick improvement. Cerebral embolism is going to mostly occur in patients that are awake, and a very first symptom is usually a mild headache. And finally, the last cause of a stroke is a cerebral hemorrhage. And this is if there is an aneurysm in a blood vessel in the brain. So we talked earlier about how an aneurysm is that ballooning of the artery. We can see that in the lower picture there. It's a weak part in the artery that balloons out. That ballooned area is also weak and it can rupture. So in a cerebral hemorrhage, an aneurysm is going to rupture and it fills that cranium, the brain space, with blood, and it increases the pressure in the brain because of all that blood buildup. So this kind of stroke is has a high death rate because of the increased swelling in the brain due to the increase of blood. The increase in pressure in the blood can cause displacement of the brain. So this is usually seen in older patients, but it could result in a younger patient if they have a malformed blood vessel. This slide is a review of the different types of causes for a CVA. So again, we have a thrombosis, which is our first picture on the left, where a blood clot is formed in the cerebral artery and blocks the blood flow in the brain. An embolism, where a fatty plaque or blood clot breaks off away from some artery and flows to the brain, where it blocks a cerebral artery, therefore blocking the blood supply to the brain. And then finally a hemorrhage, where an aneurysm bursts in the brain and the blood fills the cranial space and increases that pressure in the brain. So how will you know if your patient is having a stroke? Well, there are some pretty telltale signs of a stroke. So first, you can have the patient complain of a headache, and then they can have some paralysis. So especially in their face, there might be hemiplegia. So half of their face or one side of their face is experiencing paralysis. And we can see this with their face kind of drooping. As a result, they can get some impaired speech, have slurred or distorted speech, and that's usually because of their facial paralysis. They can have some confusion. The brain's not functioning properly, so that they're going to have some confusion and then some vision abnormalities. Another sign is the hemiplegia. So if they're unable to lift both of their arms in front of you, that might be a sign of a stroke. So there is a mnemonic device that goes with a stroke, and it's called FAST. So face, arm, speech, time. So first we're going to see, is their face uneven? Can they lift both arms in front of you? Is their speech slurred? And if any of those are the case, then we need to call 911 immediately, because time is of the essence. If a patient has experienced a stroke in the past, you may see or you may have experience with their residual effects that they have. And these can be temporary, so they don't have to last forever, but they can be permanent. So they can have a loss of memory, impaired speech. It could be temporary or permanent. Sometimes if they are having permanent paralysis in their face, they can get better with their speech with some speech therapy. And depending on what side of the brain the stroke affected and how the extent of the damage, that's going to help us determine how much residual effects they're going to have. Another thing to note for us is that they can have a decrease in salivation. And another side note I want to add in is a transient ischemic attack, or a TIA. This is what a lot of people refer to as a mini stroke. It has very similar signs of a stroke, but the client is going to recover really quickly from this. So they're not going to have any kind of permanent damage. You're going to see a little bit of a change in their either speech or their ability to function on one side of the body, but it's going to recover very quickly and leave no permanent damage. So the important thing to note about this is that if someone has a TIA, it is a strong predictor that they're going to experience a full-blown CVA over the next 6 months. So we still don't want to be providing dental treatment for 6 months, even if the patient has had just a TIA. And a lot of times patients that have had a true stroke will admit to having something similar to a TIA, but not necessarily knowing exactly what it was. The signs of a TIA are very similar to a stroke. So a headache, changes in vision, numbness, or loss of feeling on half the side of the body, and as a result, slurred speech, and then weakness in the extremities depending on which side of the brain is affected. Usually in a TIA, you're not going to get any kind of loss of consciousness, but there just might be a confused look on the patient. They're not necessarily sure what's happening because of the numbness and the vision changes. And usually it's not going to present an emergency situation in the dental office, but knowing that the patient has a history of a TIA is important because they may experience a severe stroke. So if we know that a patient is experiencing a stroke, so we go through the mnemonic device fast and we see the face drooping, the arm not being able to lift the arm, the slurred speech, we're going to immediately stop dental treatment. We're going to elevate the head slightly, so we're not going to position them all the way up to the upright position, but we're maybe the semi-supine position. And activate EMS immediately. Time is of the essence. That's the first thing that we do is call for help. That means that if you're in your dental office and you're not next to a phone, you are yelling to someone at the front desk to call 911 right away. It doesn't matter if there's other people in the operatory. We need to make sure we're doing that as the first thing because time is of the essence. And the longer we wait and the longer someone has decreased blood flow to the brain, the greater their chances of dying. We're going to be, after we call 911, we can model the vital signs and administer oxygen. And if they do become unconscious and they don't have a pulse, we can start to provide basic life support as we wait for the EMS to arrive. But there's not really much emergency drugs that we use in the case of a stroke. We just need to get the emergency medical services there as fast as possible. Finally, if a patient has a previous history of having a stroke, just like a heart attack, we want to wait on elective dental treatment for 6 months after a stroke or a TIA. Again, we're going to be employing the stress reduction protocols of a short appointment, appropriate pain control and anxiety control, and then review all meds for anticoagulants. So a lot of times after patients have a stroke, they're going to be prescribed anticoagulants, whether this is aspirin or something like Coumadin, warfarin, Plavix. So we want to make sure if they are prescribed anticoagulants that we're getting the appropriate laboratory values, that INR or prothrombin time, to determine if they're in a controlled clotting time so that we can determine if they're going to have any kind of uncontrolled bleeding risks. Okay, so that's the end of our lecture for today. If you need to ask any questions, you can comment on the VoiceThread itself or email me any questions that you have. We do have a pop quiz in class this Wednesday, and it will be on this lecture, Cardiovascular Emergencies. And we have an online quiz number 6 that will be due next Wednesday before class, and that will be covering gastrointestinal and respiratory disorders, as well as this lecture on cardiovascular emergencies.